Hey guys, good evening. Can you see me? Can you hear me? A very warm welcome once again. I'm troubling you every Sunday. Last Sunday also we were there. Good evening, Imshita. So today I'll be dealing primarily with RBC disorders. Coagulation, I'll do a little bit with general pathology, and we'll be having the next foray of pathology a week, almost week to 10 days later, right? My next will be on July 30th and 31st, where I'll be covering whatever is left behind with respect to general pathology, right? Okay. So that note, let's start without wasting much of time. The template, be it in hemolytic anemia, be it in nutritional anemia, whatever it is, with respect to an RBC disorder, we'll go with the same template. So we'll have a etiology. I want you to specify what type of defect it is, whether it's a problem in the RBC or outside the RBC. That's an intracorpuscular and extracorpuscular defect, which is important for a classification point of view as well, right? Inheritance, if it's inherited. So like disease like PNH, it's not inherited, just write acquired. That's more than enough. Need not write the inheritance because we won't have it something, right? And pathogenesis. Again, the pathogenesis, I want you to think about the marks where it's awarded. If it's a G6PD deficiency in a long answer, it makes sense for me to write everything. Short answer, write crisply, that's more than enough, right? In under the diagnose heading, history is diagnostic, CBC finding if it is useful. For most of the hemolytic anemia, CBC might not be useful for except for HS. Spherocytosis, I have elevated MCHC. But for an iron deficiency anemia, I would require the MCB, MCH, RDW, everything, right? So in relevant conditions, write about CBC. For everything, I would require a peripheral smear and investigation of choice. Or if there is an approach, the approach, right? And if you know a word about the treatment, write about the treatment, fine? Okay. Okay, good evening, Srimati. Good evening, Vinay. Fine. So this is what we are going to do for every hemolytic anemia and every other nutrition anemia, right? I want to talk about. Hi, Virat Kohli. Thank you. Let's go over the class. Just give me a second. Okay. Fine. So I want to go ahead with 6 or 7 different anemias. I think most of them will be sorted with under 6 and 7 anemias. There's a very good possibility with respect to hemolytic anemia, either sickle or thalassemia. Most likely thalassemia can come as a long answer LAQ question, and iron deficiency as well as megaloblastic can come in a long answer question, right? Rest everything G6PD or an HS most likely will be in a small answer 5 mark question if possible, right? Okay, let's go to this. I want you guys to be actively involved as usual because I'm sure most of you know the answer for all these headings, right? What do you think is the etiology for HS? Etiology is it's a defect or mutation in the RBC's membrane proteins, right? There's a membrane protein defect or a membrane protein mutation, right? So there are multiple proteins. I'm sure you know that most common is ankyrin, and apart from that you can have the band, right? Band 3, band 4.2, and your spectrin as well. So it can be anything, but most common is obviously an ankyrin mutation or ankyrin loss. Inheritance, if you remember genetics class, it's a structural protein. Any structural protein will come under only one inheritance. It's autosomal dominant. If you want extra marks, write this also. Spectrin mutation can be recessive. And spectrin mutation can be a bit more severe as well, right? It's generally autosomal dominant inheritance only, right? Pathogen is very, very simple, right? Because of the less amount of the RBC's membrane protein, that's be it an ankyrin, spectrin, whatever it is. So the RBC will lose its biconcave structure and it will become spherical. So from a biconcave structure in RBC, because of mutation, it becomes spherical, right? So that's a primary problem here. This spherical RBC, when it goes, it's an extravascular hemolysis or an intravascular hemolysis. When it goes via the spleen, right? They'll be trapped in the spleen, and once they are trapped in the spleen, by default it will be destroyed by the macrophages, the littoral cells, results in extravascular hemolytic anemia, right? A simple case of an extravascular hemolytic anemia. That's what happens in the pathogens of HS. This is more than enough. A very simple pathogenesis. It's an extravascular hemolytic anemia, and by default HS is an intracorpuscular defect as well. Okay, It's a problem in the membrane of the RBC, which is an intracorpuscular defect here. Fine. Okay. That's with the pathogens of hereditary spherocytosis. Fine. So can anyone tell me what will be the symptomatology? I'm good, Allah. Hope you're good. What will be the symptomatology? Symptomatology, history. Like any other autosomal dominant disorder, this also will be having a presentation during adult. It will not present during children, except for the spectrin defect, which will not go into it. It's an adult life presentation. So there'll be a classical trade-off. Fatigue will not be the major thing. Like Ipsa said, splenomegaly will be the most important finding here, right? On examination, right? The patient might have history of gallstones, cholelithiasis in an adult on examination having a splenomegaly. Okay, that is the classical three things I want to look of. Adult life presentation, fatigue, tiredness is a common thing for any hemolytic anemia. Gallstones, right in the corner, pigmented gallbladder calculi. It's because of the extravascular hemolysis, slowly and steadily the bilirubin increases, which might form a sludge and present as a pigmental gallbladder calculi. That's a very classical position of HS. Adult, jaundice, yes, pigmented gallbladder calculi and splenomegaly, right? Jaundice, Vinay, I generally don't go into much depths of it in case of HS because autosomal dominant, only one gene is mutated, other gene is normal, so it will be very subtle jaundice, but the pigmented gallstones will accumulate over the period of time. Fine. CBC finding is one classical CBC finding. There will be an elevated MCHC. Don't forget this. This is one of almost the only hemolytic anemia which will have elevated mean corpuscular hemoglobin concentration, right? Peripheral smear, what do you see? You classically will see spherocytes. So how does a spherocyte look? We have all the three findings. It will be smaller, it will be darker, and will have no central pallor. So this has to be there, right? So these three findings are very, very important for me. You have structures are marked as spherocytes here. Draw a diagram. It's very simple. Draw a diagram like this. A normal RBC with a central pallor, a normal RBC, and then a subtle tiny RBC, right? Smaller, darker, no central pallor, right? Just a simple description, so that will go a long way than writing the points, right? Smaller, darker, no pallor. I obviously am going to talk it as a spherocyte, right? No, Ipsita. Osmotic fragility test is not the investigation of choice. It does play a role, right? So here, like I said at the start, I want to talk about two things here: approach and investigation of choice. So let's say when a person there's an in patient presents an anemia and the diagnosis made as spherocytic anemia. When I say spherocytic anemia, in microscopy I'm seeing spherocytes, that's all. So the next step what we'll do is, obviously the next step to be done is Coombs test, because we know that the most common cause of spherocytosis is autoimmune hemolytic anemia, right? If Coombs is positive, your diagnosis autoimmune hemolytic anemia. If Coombs is negative, then yes, I suspect spherocytosis. Fine. Hi Niket, good evening. Hope your third year is doing good. Okay. Okay. Vinay, whole jolly body is seen in a peripheral smear of a Leishman stain. Heinz body is seen in a new methylene blue stain. Fine. Most of them will present with history of gallstones. Allah. Fine. Okay, if Coombs is negative, then yes, I would suspect hereditary spherocytosis. Here, yes, osmotic fragility test plays a role, but it is not the investigation of choice. What you'll have in osmotic fragility is here the RBCs will be more fragile, right? They are osmotically more fragile than a normal person's RBC. Or the spherocytes are osmotically more fragile, right? But the investigation of choice is very, very different. Investigation of choice is flow cytometry, right? EMA flow cytometry, EMA flow cytometry, fine? Okay, that is the investigation of choice. Here, approach is more important. Spherocytes means does not mean a spherocytic anemia. I want you to write, think of AIHA, negative, then yes, osmotic fragility helps to some extent, but investigation of choice by default is flow cytometry, fine? Sure, Aniket will do it soon. Okay. Now let's go to the treatment if possible. Right? Treatment is just splenectomy. If it is severe, remove the spleen. Splenectomy is one of the treatment of choice which is there in case of an HS patients. Fine. Okay, guys, if you're in second year, now in the second year exam going, don't worry about the 11th edition of Robbins. Nothing will be there in your exam. We'll see it later on. If there's any change, we'll see it later on. Right? Very subtle changes will be there. Fine. Sure, Niket on YouTube. Fine. Let's go to G6PD deficiency. So this is what we're going to do for 6 cases of anemia. Classical etiology, extracurricular, inheritance, pathogenesis, history, CBC, peripheral smear, investigation of choice, or approach if required. Fine. So now you know the routine. You guys will be telling me what to write here, right? So tell me what's the etiology of G6PD deficiency. It's there in the name, right? There is reduced glucose 6 phosphate dehydrogenase enzyme. Okay, so which is a component of right here itself HMP pathway. So there'll be a problem in the HMP pathway here. That's all fine. Osmotic fragilities will only tell me that there are spherocytes there. Osmotic fragilities will have the same interpretation in autoimmune hemolytic anemia also as like your hereditary spherocytosis. Fine. Okay. So inheritance here is X-linked recessive inheritance. Fine. That's important. So big pathogenesis, because of the reduced G6PD deficiency and reduced HMP pathway, what happens is because of reduced hexose monophosphate pathways functioning, so you will end up in having a reduced NADP-NADPH ratio. So because of the reduced NADP-NADPH ratio, what happens is there will be reduced recycling of the most important enzyme, right? Of your glutathione peroxidase. So when my glutathione peroxidase is not being recycled properly, indirectly I'm going to have the primary problem is there will be an excess amount of reactive oxygen species induced damage to RBCs. That's all is the problem here, right? It says more amount of reactive oxygen species induced damage, be it a primaquine induced, be it an fever induced, whatever it is, fine, perfect. So because of the reactive oxygen induced damage, I'm going to have two problems. Because reactive oxygen species will cause lipid peroxidation, will cause protein denaturation, right? So the lipid peroxidation will result in your intravascular hemolysis. That's one. The same lipid peroxidation will also cause your spherocyte. Because the damage to the membrane, that's all. It'll cause spherocyte. That's one. Fine. Perfect. So the same reactive oxygen species will also cause protein denaturation. Here the protein denaturation is nothing. The protein we are worried about here is your hemoglobin, right? So here what will happen? Globin will be denatured. So what I'll have, this globin denatured is the one which is in Heinz body. It's nothing but a denatured globin. And since the globin denaturation cannot be seen in Leishman stain, you have a bite cell. So bite cell is an unstained part of the protein coagulum. Okay, it's unstained part of the hemoglobin coagulum. That is your bite cell. Fine. So this is my pathogenesis. Reduce HMP pathway, reduce NADP and NADPH. I cannot recycle because of no absence of recycling. More reactive oxygen induced damage. So I have lipid peroxidation, I have protein denaturation. Not worry much about DNA because RBCs don't have a DNA, right? So history should be there. You are perfectly right, Allah. It has both intravascular and extravascular hemolysis, but predominantly intravascular hemolysis because more the reactive oxygen species, more hell have a damage, right? History has to have this name. It's a trigger induced hemolysis. After a trigger, you'll have hematuria. That's a classical history of G6PD deficiency. What all could be the trigger, right? So the trigger could be of infection, any infection under the sky. Could be drugs, like when I said primaquine. It's one of the important drugs I want you to remember, and also remember dapsone. See, these both drugs are important for two reasons. Now you have a very good knowledge of pharmacology. I don't give primaquine for a day. We give it for 14 days. Dapsone, I don't give it for a day, 6 months, 9 months, right? So more chronic I give, more impact I'll get. There is a huge list of drugs which can cause. Paracetamol also it might cause. I'm not going to give paracetamol for 1 month. Very, very unlikely, right? And also favapains. Just to complete it, favapains. Fine, these are my triggers. Post this trigger, the patient will have predominantly it will affect males. because of the inheritance, well, there'll be an hematuria, right? Hematuria post trigger. That's very, very, very classical of G6PD deficiency, right? So here I don't have any unique finding in CBC, peripheral smear directly, right? In peripheral smear, I want you to divide into two categories. What will I see in Leishman stain? What will I see in new methylene blue stain, right? So this will obviously help us to avoid the confusion what when I asked, how do I differentiate a Hobel-Jolly body versus a Heinz body, right? So here in Leishman stain, what I'll see is spherocyte, because that's a finding almost in everything, and I'll see bite cell. If required, please write bite cell on the top. Fine. Sure, Aniket, but malaria's hemolysis might happen along with renal failure and everything, because more very severe black water fever is in falciparum malaria, and I can easily differentiate them from this hemolysis. Fine. Okay. And here I obviously love Heinz body. Heinz body is a single intracellular inclusion composed of denatured globin. There is nothing but a denatured globin precipitate. Fine. Drawing a diagram is very simple. Draw a normal cell and draw cells which has been destroyed like this, right? Like a classical bite cell, fine. So that is more than enough for us to actually enough for me to confirm its G6PD deficiency, provided there is a history. But still I have to complete it as an investigation of choice. What do you think is the investigation of choice? It is as simple enzyme analysis. You analyze the enzyme, obviously you will know that it's reduced or very zero or whatever stage it is, right? So you have different classes of G6PD deficiency based on the amount of enzyme activity present in the person, fine. Treatment is simple. Treatment is just a supportive management. And obviously I have to tell the patient, see, next time you have a fever or you're taking a drug, please ask whether the interaction there or not, fine. See, whole jolly bodies will be there in post-splenectomy patient. So this image, what you saw, this is actually a whole jolly body. There's an image from Robbins. So this whole jolly body is present here because this spherocytosis patient is a post-splenectomy patient, right? That's why if you read the legend of Robbins, it will be written post-splenectomy spherocytosis. So I see an whole jolly body, fine. Okay. Supportive treatment means if there's a very severe hemolysis, give transfusion. Otherwise, wait and watch. And please inform the patient next time when you have fever, go to the OPD, if at all, even if you're seeing a drop of red color urine, right? So that's about G6PD deficiency. Same template, etiology, inheritance, pathogenesis, history. If you want to write pages for everything like fatigue, weakness, tiredness, that's non-specific. I'm just telling this specific in history, that's all, right? Peripheral smear and investigation of choice, fine. Now next, sickle. Sickle tal, possibly it can come in a long answer, right? Possibly, definitely can come in a long answer, right? Sickle, see, I'm not going into the confusion of whether it's a mutation in the beta 6 portion, beta 7 portion, not there. Till it's going to be changed in our standard books, we'll go with the same thing, fine. So etiology here, I'm going to have a point mutation, okay, in the beta globin gene, the 6th position between glutamine to valine. Okay, this is what happens, fine. Says glutamic acid to valine or glutamine to valine, right? This change in the glutamine to valine is my etiology, right? Inheritance, it is obviously an autosomal recessive inheritance. This obviously it's also an intracorpuscular defect. There's a problem in the hemoglobin, it has to be an intracorpuscular defect, right? So pathogenesis is same due to my change. Since glutamine becomes valine, I'm going to have a hemoglobin which is less soluble, right? So pathogenesis, HPS, because of the mutation, becomes less soluble. So it becomes a precipitate. Obviously, anything's less soluble will become a clump or will become a precipitate. This is the problem, right? So this hemoglobin clump or hemoglobin precipitate is going to cause membrane damage. Okay. And one important thing I want you to write here, and this clumping and membrane damage, everything will be more in a deoxygenated state. Clump formation as well as damage will be more in a deoxygenated state, which means when oxygen comes back, it is a reversible process. Sickling is always a reversible process till a point of time where my RBC's membrane is very much damaged, it becomes irreversible. Fine. Okay. So first thing, you have a simple normal RBC. From that, okay, it becomes less oxygen, less O2, or extremely high amounts of sickle, HBSS. These are predisposing causes, right? So it causes membrane damage. When there's a membrane damage, automatically it can turn to poikilocyte. One of the poikilocyte is a sickle, right? So here I will use the term reversible sickle. Because this reversible sickle, the reason is if there's going to be an oxygenation, this reversible sickle can definitely come back to normal, right? It will definitely come back normal. It is a reversible cycle, right? But at some point of time, with repeated amounts of oxygenation, there's a possibility you'll have repeated attempts of sickling. There's possibility it can become an irreversibly sickled RBC. So once it becomes irreversibly sickled RBC, the same routine, it also will undergo extravascular hemolysis. Be it a round RBC or a sickled RBC, it gets stuck in the spleen. It will become an extravascular hemolytic anemia, right? So now the problem is not that, the reversible sickling. This reversible sickled RBC has a more tendency to bind to your endothelium and can form clumps, right? This increases the clumping of RBCs, not the protein. So once they clump the RBCs, they can go and block tiny vessels because they can stack one on top of each other, which can block tiny vessels. That's my most important history and the most important pathogenesis. So please highlight on this because this causes your vaso-occlusive crisis. Irreversible sickle causes anemia. That's all. Normal RBC, because of all the conditions, becomes an clumped RBC, clumps HBS, which will cause membrane damage, which becomes reversibly sickle, which has the capacity to block the vessels, vaso-occlusive crisis. It's a reversible process, again and again can come back normal. Repeated attempts will make it irreversibly sickle. Those sickled RBC will get stuck in the spleen and will have hemolytic anemia, fine? So the history here has to always be based on vaso-occlusive crisis because that's the most common history here, right? I'm not telling this patient might not have anemia. Anemia will be there. In homozygous patient could be even a severe anemia. But still, vaso-occlusive crisis is very, very important for me. History is most of the time because of vaso-occlusive crisis. Sickle is a painful anemia, not like that. That is purely anemia, right? Perfect. Pain in dactylitis, you mean, Ipsita? Pain in the digits, right? That's the most common cause or the most common symptom is going to be dactylitis. Pain in the fingers. Yes, men can present with priapism in more than 40-50% of the patients. You might have a non-healing ulcer. Okay, that also is due to your thing, or just an unexplained abdomen pain. I don't know what's the problem, but it's an unexplained abdomen pain. So this unexplained abdomen pain over the period of years can result in an autosplenectomy, right? Because unexplained abdomen pain means tiny infarcts must have happened in the spleen over the period of years. So can become autosplenectomy, can be destroyed, right? So there are few complications of vaso-occlusive crisis also. It can actually present as an respiratory distress, right? It can actually present as an acute chest syndrome. That also could be a presentation mimicking your MI. Similar to MI, could be presenting as chest pain also. That could be a complication, not a general presentation. It's fine, Ipshita. In addition to this, you'll have all the features of anemia. Plus, you'll have all the features of anemia. Right? You can write the fatigue, pallor. If it's an homozygous sickle cell anemia, you can write this happens very early in life. Heterozygous happens a bit late in life. You can put a table and write homozygous, heterozygous, that's carrier, and a full-blown sickle cell anemia, right? Okay. So peripheral smear, I don't have much finding here also in CBC. It's not a classical thing which you can get in CBC. Peripheral smear is simple. Classical thing is sickled RBCs or drepanocytes. Okay, so you can draw a drepanocyte. It's very, very simple to draw a drepanocyte. You might also see target cells, write them also. Target cells also a finding seen in case of a sickle cell anemia, right? This for a very easy or an homozygous sickle. What will happen when you have a heterozygous sickle? That will write in the approach or the investigation of choice, right? Because approach is something which is important. For a homozygous sickle cell anemia, doesn't matter. I can easily diagnose and say sickle cell anemia. If the patient is a carrier, for a carrier or a heterozygous sickle cell anemia, I might require to induce sickling. So we have a test called as a sickling test. So the idea is very simple. The principle or the mechanism of action of sickling test is induce deoxygenated or hypoxia state. Okay, so I just need something to suck up oxygen in a peripheral smear, right? So what is a chemical? Anyone? What do you see do in sickling test? It's simple. How it's done, the principle of sickling test, how it's done is you just add a drop of blood. Along with that, you add what's a guy? Sucrose water is not for this vinay. You add sodium metabisulfate, right? We add sodium metabisulfate, that will absorb all the oxygen there. So this will induce sickling. So this is primarily the approach what I'll be doing for a carrier. I suspect there is a vaso-occlusive crisis. You do a peripheral smear, more or less normal, induce a sickling. If it's positive, if it's positive means I'll see sickle cell in the microscope. That's all. Fine. So I can say it's positive. Then I can go for an HPLC if required. Right. So once it is done, obviously I have to come to the investigation choice. It's undoubtedly your HPLC or an hemoglobin electrophoresis. In sickle, more or less both are decent enough. I don't have a huge difference between HPLC and hemoglobin electrophoresis with respect to sickle. Thal, yes, significant difference. Sickle is a very pretty easy diagnosis. Fine. Okay. So now treatment. I want two treatments. One obviously is a bone marrow transplant, CRISPR, all the hi-fi things. But there's a drug which can actually increase the HbF and actually can increase the oxygen level. What is the drug? So I have a drug which is hydroxyurea. So hydroxyurea actually increases the HbF by the way it increases oxygen saturation. So obviously it will reduce the sickling and reduces the painful episodes. That's one. And obviously the next one is I have a bone marrow transplant and the first disease where CRISPR-Cas9 technology is used for a genetic modification. It's been done and there are successful patients who have come out of the sickle cell anemia and completely cured by CRISPR gene modification, right? Write a note on both of them. Hydroxyurea should be there. It's there in Robbins also, it's there in your Tripathi, and since pharmacology is over, you can easily afford to write one line about treatment for any disease. Write this for microbiology also. Don't stop with microbiology as microbiology. Convert into the next step, prognosis, complication. That makes the entire question have a rounded appearance rather than just sticking to pathology, little bit of micro, little bit of management as well. Fine. So that's about sickle cell anemia. Same routine. We have just 2 slides for every disease. Most of them will be covered here, right? That's more than enough. And if it's a long answer, I need not teach you how to make it 4 slides. You'll definitely know. Write slowly, expand it. Fine. Thal. So what's the etiology of thalassemia? Anyone? When I ask about etiology, I don't want you guys to answer that I'm going to have no beta cells or the no beta globin chain, right? That's the outcome. What is the mutation case of thalassemia? We have multiple mutations and we have beta 0 and beta plus as well. We can have splicing mutations. We can have the promoter gene mutations. We can have chain terminator mutations, right? All this can happen in case of thalassemia, fine? So etiology here is, here also, beta and alpha will predominantly focus on beta. We'll write beta thalassemia. In beta thalassemia, I'm going to have beta globin chain mutations. There are multiple things there. Splicing mutation is one of the most common one. Fine. We'll see that soon. Hopefully we'll have something. Fine. The most common is obviously splicing mutations. Right. If you can remember, write this IVS 1 to 5, G to C. Splicing is problem in the cutting the exons and introns and uniting the exons, right? So in that intervening segment, intron 1, fifth portion, I have G to C transition. This, if you can remember, write this, right? Then I have your chain terminator mutations. So chain terminator mutations is the stop codon comes here, right? This is primarily for beta 0, this is primarily for beta plus. Okay, that's what the splicing in chain terminator does. And also we might have something called promoter region mutation. Okay, so these are three mutations mentioned in Robbins. I want you to write all three because it is important for us at least to have the name. If you can write this, it will be great. IBS 125 G2C as well, right? That's a problem. It's a beta globin synthesis problem. That's all, right? Inheritance is autosomal recessive and absolute intracorpuscular defect, right? Now let's come to pathogenesis. The pathogenesis is simple, right? When I have a beta gene problem, beta globin is not being there. So what happens? Reduced beta chain unfortunately will increase the alpha chain. So it makes it an 4 alpha. Instead of having 2 alpha, 2 beta in an adult, in a normal adult, hemoglobin will have 2 alpha chains, 2 beta chains. From that, it's going to become 4 alpha because of reduced or absent beta globin, right? This 4 alphas will obviously clump. It will clump inside proerythroblast. Because it clumps the moment hemoglobin is formed, it's not going to wait for oxygenation, deoxygenation, or a trigger like GSPD. Clumps in the bone marrow itself, right? So once I have that, this will actually destroy proerythroblasts. Quite a few of them will be destroyed, and few of them will escape. Few which escapes, unfortunately, there will be smaller blast and irregular blast. Because it's damaged one, right? Since it's small and irregular, that's why I have the RBC which is formed also microcytic. Hypochromic is easy, it's extrapolated, and extreme amount of anisopoikilocytosis. Also the target cells. Target cell is nothing but an poikilocyte, that's it, fine. Since majority are destroyed, the proerythroblasts, this will result in excess amount of bone marrow hyperplasia. Okay, that will obviously that bone marrow hyperplasia will definitely be there, right? So we know why there's an anemia, because half of them are dying, only half is coming outside. It's a simple pathogenesis. You can write in addition to it, because of the bone marrow hyperplasia, we have few classical problems. Okay, because the bone marrow hyperplasia, what are the problems? Anyone? Too much of bone marrow is becoming bigger and bigger and bigger. So I can have the facies. This results in your hemolytic facies. That's one, right? Second, in spite of having so much bone marrow hyperplasia, still it's ineffective, right? There is bone marrow hyperplasia, but still can't correct the anemia. Still it cannot correct the anemia. So I'm going to call it an ineffective erythropoiesis. Okay, this word is important. If it's a long answer, I would expect this word in your exam paper in pathogenesis. It's an ineffective erythropoiesis, right? If it's an ineffective erythropoiesis, who will come and help me? Spleen. Because of this, the spleen produces erythropoiesis, or spleen helps in the RBC production. That's why you have extra medullary hematopoiesis, which results in a splenomegaly. Here the problem is not destruction in the spleen, destruction is in the bone marrow. But still, I'll have a splenomegaly because of extramedullary hematopoiesis, right? These two words are must. So it's not the etiology, it's the outcome of the pathogenesis, right? Bone marrow hyperplasia, phase will change, and spleen will be there, ineffective erythropoiesis. These both are required, right? If you want, you can write it here, or you can write it when you come to the treatment about the secondary hemosiderosis and the secondary iron overload, right? So history, with respect to THAL, if the general question on thalassemia, write for both major and minor. But if the exam says it's a LAQ, right? 5-year-old kid having severe anemia, right? Only symptoms of Thal major. Thal minor will not present at 5-year-old, right? So if it's Thal major minor, symptomatology is simple. This happens at 6 months of age. Classical failure to thrive. Kid will not be able to grow properly, and your classical hemolytic or your chipmunk phases, right? Hemolytic or chipmunk phase is very simple. You'll have very prominent frontal bone, prominent zygoma. Okay, all these will be very classical and prominent, right? That's one thing for an uh, thalassemia major. Perfect. Minor generally is in adolescents or adults. The thing about minor is most of the time they are incidental diagnosis. They are almost like similar to any anemia. It's like very, very similar to IDA, right? That's how we'll come into. It's very similar to an iron deficiency anemia or an, just fatigue. Randomly you do an peripheral smear, you see a target cell. They are instantly diagnosed only. Thalassemia minor, fine. CBC finding. CBC is important here because one of the closest differential diagnosis is iron deficiency anemia, right? So you'll have microcytic or reduced MCV, reduced MCH. The most important thing, I want you to write both RDW as well as Menster's index. See, we did read about the classical reason of RDW and Menster's index when we read the entire pathology, right? As I told you why there's an RDW, it's a red cell distribution with the different in the pathogenesis, a static error and a dynamic error like an IDA. That's why this happens, right? At the final moment, whatever said and done, there's an easy way to remember it. It's thalassemia, right? So both will be less. It's the thalassemia. Okay, here's less than 13. RDW will be normal or reduced. Again, it's less, right? Lower RDW, narrow RDW, and less than 13 Menster's index. RDW will be elevated or wider in case of an iron deficiency anemia, and Menster's index will be more than 13 in case of an iron deficiency anemia, right? It's thalassemia, so both will be less, and these both has to be there in a CBC because this will help me to differentiate whether it's an microcytic iron or microcytic thalassemia, right? Peripheral smear also has a major difference between your Thal major as well as a Thal minor, right? Thal major and Thal minor, one of the common thing, again, here lab, I'm writing MCHC for microcytic hypochromic anemia, both the same. So if it's a long answer, right, microcytic, RBCs are smaller than the nucleus of small lymphocyte. Hypochromic, RBCs are paler, more than one central one-third pale, right? In addition to that, both will have target cells. That also is very, very classical. Both will have target cells, both major and minor. You can write target cells, you can write codocytes, you can write both. The one thing which is classically seen in major, like Ipsa said, I'll have increased blast in the peripheral smear. That's my nucleated RBC. Nucleated RBC or an NRBC is classically seen only in major. You will not see a nucleated RBC in a minor. Rest everything is seen in both same. Fine. Okay. Investigator choice here. I'd prefer HPLC. Is definitely bit better than hemoglobin electrophoresis. Okay. Just if you want to show off the knowledge a little bit, you can write that HbA2 level will be elevated in patients with thalassemia. That's a clue for me to say it's thalassemia. This could also be in the long answer question. A2 elevated, anemia in the child. Think of a thalassemia. Fine. HbA2 elevated is almost always you have to think of a thalassemia. Fine. Treatment, two options. Most often, this is what we'll do: repeated blood transfusion. The problem with repeated blood transfusion is this will cause secondary iron overload and secondary hemosiderosis. So to avoid that, I by default have to give your iron chelators. You guys know the iron chelators. What are the iron chelators comes to mind? Desferoxamine, deferrizox. You have to give them so that I can reduce that, right? And the best is bone marrow transplant. If you get a donor, the best has to be a bone marrow transplant, fine? What is this? All these are the same guy, codocytes or a target cell. right? And this is your NRBC. So if you are drawing a diagram, I want you to show the difference between a major and a minor. Draw two small circles, major, minor. Minor will not have NRBCs. Major will have both NRBCs as well as your target cells. Fine. Okay. Perfect. Right. That's about thalassemia. Thal can come in a long answer question. If it's a child, severe hemolytic anemia, only two possibility. Thal or sickle. Sickle will have painful episodes. Thal will not have painful episodes. As a classical difference between sickle and thal. You can easily differentiate. Generally, sickle will not present at 1 year, 2 year. If it's 1 year, 2 year, hemolytic anemia, thalassemia. Non-hemolytic, by default, iron deficiency anemia. Fine. Okay. Let's go to the next guy. IDU. If I'm the examiner, I'll ask nothing related to hemolytic anemia. Not common. This is the only thing which I'm worried about is iron deficiency anemia, because the moment you become a doctor, you sit in an internship, the only this anemia you will be keep seeing again and again and again is IDA. And I want you to know everything about IDA, right? The first thing, it's a most common cause of anemia. And any I think that will be uniform across the world. The most common cause is iron deficiency anemia, right? Children, the etiology could be worm infestations and nutrition. Nutrition is common for all, right? Adults, again, the first thing is nutritional deficiency. Okay. If it's a woman of the reproductive age group, menstrual irregularities. Because that more and more loss of blood, menorrhagia by default can happen, right? Elderly, we saw in colonic carcinoma as well. An elderly with an iron deficiency anemia always test for occult blood in the stool. And if the occult blood is positive, think of a colonic malignancy. Because elderly is very unlikely to suddenly have a nutritional deficiency, right? Till for 60 years, good nutrition, suddenly it will not have nutrition deficiency. Suddenly worm also will not happen that point of time, right? Elderly IDA, check for adult blood loss, positive, do a colonoscopy, most likely will be colonic malignancy, fine? Okay, I want you to write all this is important, this is important, this also is important, and nutrition by default is common for across all the three age groups, right? So we know the etiology. Pathogenesis. Robbins does not talk about these three stages, but if you can, talk about them, because this is how iron deficiency anemia has been present in Harrison and any other medicine textbook. I have a stage of negative iron balance, stage of iron deficient erythropoiesis, stage of iron deficiency anemia, right? So it's simple timeline, that's all. So I have less iron, because pathogenesis is very simple. If iron is not there, hemoglobin cannot be formed. It's not a rocket science to go and write in the pathogenesis. Iron is required for hemoglobin and RBC, that's it, right? So when iron is reduced, the first stage what happens here is, here the iron will be borrowed from ferritin, serum ferritin, not the duodenal ferritin, right? It's borrowed from the serum ferritin, but still your erythropoiesis is absolutely normal and there's no anemia. When erythropoiesis is normal, I won't even expect there will be anemia here, right? So now when it comes to the second stage, the stored serum ferritin is, the storage form is lost. When serum ferritin is lost, so I am actually deficient of iron here, right? So actually the bone marrow will not have enough iron. So when the bone marrow does not get enough iron, it's simple. So here I'm going to have, the problem is erythropoiesis will be defective. When erythropoiesis is defective, they do produce microcytic hypochromic RBCs, but it will not become an anemia, because I have produced for the last 120 days good RBCs. Today it's becoming abnormal. Doesn't mean I should have anemia. It should continue, right? It should continue at least for 3-4 months. Only then I'll have the stage of iron deficiency anemia, right? So when iron deficient erythropoiesis continues, slowly and steadily, you'll end up in having an iron deficiency anemia. Here, you'll have reduced hemoglobin, you'll have microcytes, you'll have hypochromic RBCs, everything will be present only here. In the first stage, what will change is serum ferritin. Here, serum ferritin will be gone. Here, Serum ferritin will be gone, TIBC will be abnormal, your transferrin saturation will be abnormal. All those abnormality will happen here. Here, I'll have reduced ferritin, problems in reduced TSAT, and elevated TIBC. Everything will be here. Serum iron will be reduced, everything will be here, right? So the only thing here is it will not translate to anemia. That's why the third stage is iron deficiency anemia. These stages are must for you to write if it's a long answer. Short answer, just write simply reduced iron, not going to the RBCs enough or bone marrow enough. So obviously the outcome is going to be smaller RBC with less hemoglobin. That's it, fine. Clinical features, write the entire thing, whatever you know. Please don't forget koilonychia and hair changes. These are must. Fatigue weakness is a common template. In addition to that, if it's a child, add the problems of worm infestation. You can add it, right? Menstrual irregularities, you can add it as a component of the history taking, right? Nail changes, koilonychia has to be there. This is something which is very, very, very classical, right? Hair changes, there'll be an hair loss and a sparse hair. If you are having time and if you want to write more things, you can write about Plummer-Wilson syndrome as well. Though it's not very common, but this attracts the examiner, right? You can have Plummer-Wilson syndrome, where you have an iron deficiency anemia plus esophageal webs. The webs in the esophagus, that's classical for an Plummer-Wilson syndrome. Perfect, right? Whatever Ipsy said is also right. I can also add on to pica in children. Adults might not have pica. Definitely pica will be there in case of a child. Great, Ipsita. Okay, that's a history. CBC, you guys, Srimati exactly told what's required in CBC. I'm not writing about hemoglobin, it will be reduced. MCV will be reduced. MCH will be reduced. MCHC will be reduced. RDW is important to write this. It will be wider. And your Menster's index will be more than 13. Okay. All these are classical finding in case of a CBC. All will be present. You know the peripheral smear, right? Yes, YouTuber, right. Shubhu, it will be there in the Telegram channel. The Telegram channel is actually in the pinned comments. You can have a look in that. Fine. Okay. RBC number will be increased. That's why Menster's index will be more than 13. Fine. So the RBC numbers will be reduced. So the Menster's index is more than 13. Fine. Okay. Now let's go to peripheral smear. To know the finding, I want you to write what does microcytosis means. The lymphocytes comparison. What does hypochromic RBC mean? More than 1/3 pallor. And also the classical finding, I don't want you to miss on pencil cells. Pencil cells are a must, right? Elongated hypochromic cells. I want both the term, not just elongated. It should be elongated and it should be hypochromic, right? An elongated hypochromic cell is a classical pencil cell that is definitely been there, fine? Okay, fine. That's classical for an peripheral smear. Investigator of choice is nothing but your iron profile. Iron profile is the investigation of choice. Fine. So 4 things here. Serum iron. We know the directly proportional and inversely proportional, right? And transferrin saturation. These two are directly proportional. Reduced. And your serum ferritin. There's a very, very, very sensitive test and the very earliest finding as well. Reduced. And TIBC, which is the affinity when ferritin is reduced, this will be increased. That's an inversely proportional one, right? When you can write whatever cell numbers there are lots of name cells, you can write all of them here, fine? Okay, so that is classical iron profile for an iron deficiency anemia. Beyond this, it is not required. There are many more stages as well, but it's not required, right? The best obviously is bone marrow iron, but no one is going to take the bone marrow biopsy for a simple iron deficiency anemia, fine? Okay, perfect. Now treatment. I want you to write treatment. Ferrous sulfate, ferrous fumarate, ferrous ascorbate. Whatever comes to your mind, write it. But what is important is post-treatment. This is very, very important. The purpose of writing treatment is not treatment. The purpose of writing treatment is to how do you assess treatment response. This is very, very important with respect to a test. Person feeling better is fine. Symptomatic improvement is fine. But after 5 to 7 days of treatment, there should be an increase in the reticulocyte count. This has to be there. If it's there, perfect. The patient is having a very good response with iron, right? That this has to be there. This is must for you to go and have a look at it. Fine. Okay. Perfect. If you know how to calculate iron, it is being taught in your pharmacology. Write that also. Fine. Okay. Srimati, those are very difficult parameters to see. If you take a month of iron, yes, hemoglobin will definitely raise by a gram at least for a complete month, but there's something which is easily calibrated. I can easily do it, right? It increases reticulocyte count, it's working by default. Fine. Okay, now let's go to megaloblastic. First thing is megaloblastic is B12 as well as folate deficiency. Read the question. If it is a vegan diet, write only about B12. Don't go and write about folate there. Or it's a pernicious anemia, autoimmune gastritis, write only about B12, don't write about folate, right? If it's a problem in this, diets lacking the fruits, alcohol ingestion, or the patient is having a methotrexate drug, dihydrofolate reductase inhibitor, then write only about folate, don't write about B12. You have to know if it's an LAQ, what to write. Not an LAQ, just write these are the causes: B12 deficiency, folate deficiency, right? Etiology: vegan diet, no milk protein, no animal protein, malabsorption. There's a long list of malabsorption, right? It could be a problem in the stomach. You can either have an autoimmune gastritis or a pernicious anemia. You can have an gastrectomy being done, or I have a chronic pancreatitis, because in pancreas is gone, my absorption of B12 also will be a problem, or I have an excess growth of bacteria in this ileum, bacterial overgrowth syndrome in the ileum, okay, right? Or you can have an ileal resection. Hi Anonymous, all the best, do well. See you soon in the next year. Fine. Ileum has been completely removed. Or the last but not least is tubulin. That's a receptor mutation. Okay. So all these could be the cause of an absorption defect, right? It could be anything. Most likely it will be pernicious anemia or surgical removal of some particular organ or the body. Fine. Folate, that's all. Excess requirement during adolescence, during pregnancy. Diet lacking fruits and vegetables, because fruits and vegetables have high folate, because folate is a heat labile protein. Milk also has, meat also has, but it will be destroyed when we cook, right? Alcohol and drugs. MTX is methotrexate, dihydrofolate reductase inhibitor, right? Pathogenesis, this is the only pathogenesis I want you to remember. This word has to be there in the exam. It's a nuclear cytoplasmic asynchrony. So what do I mean by this is, because of B12 or folate being reduced, so there will be a reduced thymine synthesis. Okay, because thymidylate synthase enzyme requires the B12 and folate as a cofactor. Because of this, there will be reduced problem in the DNA production. Not just the DNA production, also your DNA maturation. But it's thymine, right? RNA does not have thymine. It's a thymine deficiency. So RNA production and maturation is completely normal. So since RNA production maturation is completely normal, cytoplasm matures properly, but the nucleus does not mature. DNA has a problem, so nuclear maturation is a problem. Okay, so nuclear maturation is a defect. That's a problem here. That's why I have nuclear cytoplasmic asynchrony. Fine. This is very, very important. Cytoplasmic maturation is completely normal, but nuclear maturation is having a problem because of thymine problem, right? That's more than enough. But if you want to write, if the question is about B12 also, add an extra point to this. This also B12 defect or B12 deficiency will also reduced myelin synthesis. Folate will not have this, right? Only if it's a B12, because that's why we have the problems in the neurological deficit with respect to B12. Will not have it with respect to folate. Fine. Okay. Clinical features and lab history. Few things has to be there. Beefy tongue, all those things are examination findings should be there, right? So history here, you will have few classical findings in history. One is knuckle hyperpigmentation because of repeated injuries to the skin over the joint prominence, right? You might have altered bowel habits because of the villi, and you might have symptoms of pancytopenia. So when I write symptoms of pancytopenia, you can write anything. Could be anemia, could be an leukopenia, could be a thrombocytopenia. Fine. Here only, Vinay, nuclear maturation is later after the cytoplasmic maturation, right? Okay, fine. You can write of all the three things because I am having a problem. The DNA blast will not be proper, so all the three lineage will be affected, right? Then you can have on examination, you can write the finding of the red beef-like or a beefy tongue or a very flat red colored tongue with loss of papillae, and you can have your neurological symptoms, right? Often problems in the position sense, vibration sense, right? Or of the lateral and the ventral spinothalamic tract, right? Neurological symptoms of tingling, right? All this will be there in case of B12. If it's folate, don't write about that, fine. CBC findings, elevated MCV, that's what is very important for me. Anything more than 100 femtoliter, I'll call it a macrocytic RBC. That should be more than here, enough for us, right? Peripheral smear, two findings. You can either write macrocytes or a very perfect finding is macroovelocytes. It'll be bigger and a little bit oval, right? These are macroovelocytes. They are not just big, they are big and oval, right? And obviously, I'll have to write hypersegmented neutrophils. See, hypersegmented neutrophils has two definitions. One, I have 3 or 5% of neutrophils more than 5 lobes. India, it's a different thing. In US, it's a different thing. Some countries say 5%, some countries say 3%. So that's why I put 3 of slash 5% of neutrophil having more than 5 lobes, or even a single neutrophil having more than or equal to 6 lobes. Okay, it has 5 lobes. I'll call it a hypersegmented neutrophil or something like this. There's more than 6 lobes. That's enough for me to call it a hypersegmented neutrophil, right? Investigation of choice is your B12 or your folate assay. That obviously will tell finally that, okay, B12 and folate is less. That will be the investigation of choice. Treatment, do mention this. If it's a only B12 deficiency, the older methodology is to treat both, but here now you treat with only B12. Folate doesn't have a problem. Only B12 deficiency, treat only with B12. Fine. Possible folate supplements along with B12 in patients with only B12 deficiency, yes, will worsen the neurological symptoms, but not the anemia, right? Because B12 is involved in two places. If I give both B12 and folate, only the DNA will take it. Myelin will be exhausted, right? That's why giving both B12 and folate in only B12 deficiency is wrong. Give only B12. If there's folate deficiency, I'll give both. Fine. Okay. Schilling test Figlu. Vinay, you can write as a passing mention, but as on date, Schilling or Figlu does not have hold any sense because it's a pernicious anemia. Why do I need to go with Schilling or Figlu? I can easily do an antibody, right? Look at the autoantibody levels in the blood sampling. That should be more than enough for us for pernicious anemia, right? That's about your megaloblastic anemia, right? So we've seen HS, we have seen G6PD deficiency, sickle, thal, IDA, and megaloblastic. These are some things which I feel are very important. PNH, I'm not sure if it will come in an exam as a 5 mark. If it comes, great. But there's a very likely possibility it can come in a Viva because it's a very unique thing, right? So just few words about PNH, or as a 2 mark it might count. It's an acquired disease. It's not an inherited condition where you have mutation in the PIGA gene, which codes for GPI proteins, the glycophosphatidylinosterol proteins. Fine. Ipsita, in folate deficiency, I don't have much of a change. If I give B12, it's okay. I give B12, that's all. It's not a blunder in folate deficiency to give both, but it's a blunder to give both in B12 deficiency. Fine. Okay, you can give both in folate or only one in folate also is completely fine. Fine. Okay, so because of this, what happens is the pathogenesis is very simple. Because of reduced GPI anchored proteins. So the GPI anchored proteins are your CD55 and CD59. When these are reduced, my RBC is going to have more and more about of complement mediated lysis at the night. When everyone sleeps, the pH reduces, complements will be activated and it will be reduced at night. Fine. Okay. Which part, Mane? Dhyaneshwar? LIQ is there for almost every college, right? Okay, that's what happens. Fine. So what symptomatology here will have symptoms of pancytopenia. So you can write whatever it is. You'll have anemia, cytopenia, leukopenia, and thrombocytopenia, right? When I say symptoms of pancytopenia, right, you will have fatigue, you'll have tiredness, you'll have recurrent infections, you'll have bleeding spots, purpuric rashes. In addition to this, please don't forget this. There also will be an increased risk of thrombus. There'll be thrombotic episode. This has to be there. Don't forget this, like your Budd-Chiari syndrome, right? Or like a stroke, right? MRLDAF is other names. You're right. Okay. So this is how it is. It's pancytopenia. CBC is pancytopenia. Peripheral smear does not hold any value here. There's no finding for PNH in peripheral smear, right? So once I know it's a pancytopenia, so obviously the second thing I do is bone marrow. So here it will be a cellular bone marrow. It's not an hypocellular bone marrow like in aplastic anemia, right? So then how do I do is an investigation of choice. Here is where sucrose lysis test was there, Vinay. I don't use sucrose lysis test anymore now. It's simple. It's flow cytometry for two things. I can do flow cytometry for CD55, 59, or I can do flow cytometry for one more protein called as FAARE. FAARE is a blessed fluorescent aerolysin, but for 55 is also more than enough. Fine. Sure, Sheikh. Hope to see you soon. Okay. Is in short about your PNH. If it comes as a short note, let's go and have a look at it. Fine. Okay, guys. I'll cut it short today. We'll definitely look at the coagulation thing along with the general pathology when we look at the fourth chapter. Along with that, we'll look at this as well. Fine. Okay. Any doubts? Let me know. I'll give you a bit of break from pathology for the next 10 days. You'll have pharma and micro mostly. And we'll look at the path again. Fine. Which graph, Vinay? You want to explain the graph of osmotic fragility? What graph comes in RBC? Which graph? I'll have it, Abhishita. Along with general path, we'll have in last 30th and 31st May, we'll cover that. Fine. CD55, CD59. Okay. I don't know what you are talking about, the flow cytometry graph. See, flow cytometry graph of 55-10. Let's assume this is a flow cytometry. We have CD55, we have CD59, right? How flow works is this is double negative, right? Okay. This is double negative, this is double positive, this is x-axis positive and y-axis negative, this is y-axis positive, right? Fine. I'll try to do something before that, Srimati, if possible. I'll do it. Fine. Okay. Here, if I have few cells here, that's more than enough for me. Even few cells here, diagnosis PNH. It's okay for me to have cells here. The reason why this happens is this is an acquired disease. It's not congenital. It's acquired disease. So means this patient has normal RBC as well as mutated RBC. That's why you'll have cells in both the places. But even if I have few cells which are double negative, that's more than enough for me to say it's an acquired mutation, right? Okay. Ipsita, anthracite coal is not that much inflammatory to ignite the reactose species to cause more damage and more cancer formation, right? That's how it is. Bituminous coal is more uh, inflammatory, more react to oxygen species production, and can cause actually more DNA adducts. That's why bituminous coal causes cancer. Fine. Okay. I'll do one thing. I'll take, if your exams is in the early part of July, if it's okay for you guys, can I take somewhere around 5 o'clock, sometimes in between, so that we can complete it? You'll have the second FAARE of other subjects at 6:30. Is that okay? If it's okay, I'll take that. Fine. Okay, guys. Thank you. Thank you for your time. See you in the next class.